My name is Daniel Carlisle, and the individuals presenting in this conference today is Allie Clausen, Ashley Mendoza, Brittany Nielsen, Casey Carver, and myself. We chose the topic for this conference since many of us have experience with delirium in this population and realize the detriment that it can inflict on patients and their families. Within this conference, we will cover what is delirium, what makes this population at risk for developing delirium, signs and symptoms of delirium, pharmacological and non-pharmacological treatments for delirium, holistic management of delirious patients, and implications surrounding delirium. Here are the phases of delirium. They can be young or elderly, but people usually are over the age of 65 and are more at risk of developing delirium while admitted to the hospital. First topic will be discussed. What is delirium? Delirium is a syndrome characterized by a sudden fluctuation of mental function. Delirium can make the elderly have an inability to pay attention, disorientation, confusion, and fluctuations in their level of consciousness. Delirium is different from dementia in that it is temporary and can last up to 6 months past discharge. Dementia is a progressive chronic condition that is with the patient for the rest of their life. There are many factors that put this population at risk for developing neuropsychological complications such as delirium. It occurs more often in patients who are over the age of 65 and have many vulnerabilities and comorbidities. The average life expectancy has increased in the past couple of decades, and by year 2030, there will be an average of 7.1 million elderly individuals in the United States. There are many vulnerabilities and comorbidities that increase this population's risk for developing delirium. They can range from anywhere between unfamiliar surroundings to malnutrition to cognitive impairments. In addition, a previous history of delirium can increase this population's risk for developing delirium. Now we will discuss the types and subtypes of delirium. Delirium is divided into 4 categories, which are hypoactive, mixed, hyperactive, and no type. Hypoactive delirium occurs whenever there is a slowing of neurological response to stimuluses, as with patients who are lethargic or coma-like. Patients are said to have mixed delirium whenever symptoms are relatable to both categories, which are hypoactive and hyperactive. It can be on both ends of the spectrum. Hyperactive delirium is characterized from an overstimulation of the brain and can cause agitation or make the patient become combative. No-type delirium is those symptoms and signs that cannot fall into any of the categories.
Delirium can often be traced to one or more contributing factors. This can be a severe chronic illness, changes in lab results such as metabolic balance, changes in electrolytes, medications, infections, surgeries, alcohol or drug use, with or without withdrawal. Because symptoms of delirium and dementia can be similar, it's really important to grasp input from patients' family members or caretakers, as well as doctors, like their primary care, or they have a specific physician that they see often to make sure the diagnosis is accurate. Signs and symptoms of delirium usually can begin over a few hours to a few days, so it varies with each patient. They can fluctuate throughout the day. Some patients go all day fine with symptoms of delirium, and at nighttime, they experience symptoms. Things are less familiar at night. Most family members may go home if they're visiting, whether they're an inpatient in a hospital or at a nursing home, so they don't have any familiar faces around too, which can help cause some of the symptoms of delirium. Reducing awareness in environment and poor thinking skills are two of many categories that can help define symptoms of delirium. So it's kind of difficult to diagnose delirium based specifically on these categories because some of these can be normal for aging. So it's very important to know the patient's baseline awareness of environment, baseline thinking skills, or cognitive impairments before evaluating for delirium. Some of the results for reduced awareness in the environment would be an inability to stay focused on a topic or switch topics. So if they can't stay focused on talking about one thing and just kind of switch to a new topic, getting stuck on an idea rather than responding to questions or conversations. So kind of like avoiding the questions unintentionally, being easily distracted by unimportant things, being withdrawn with little or no activity, or less responsive to environment. So it's really important to make sure that you know the patient's baseline because some of these can happen with aging and the aging process, and these are also some of the symptoms of dementia. So it's really important to know the baseline. Some results that may appear from poor thinking skills would be poor memory, particularly recent events. So if a patient is admitted into a new place and they can't remember, like, oh, where did I put my glasses? And they're right there beside them. Little things like that. Disorientation, for example, not knowing where they are or who they are or who is sitting next to them without being prompted to know where they are. So the patient's recently admitted into the hospital, besides their illness, such as a UTI, that can also impair their cognitive results. It's important to kind of keep an eye on that too, to make sure it's not due to an illness. Difficulty speaking or recalling words, rambling or nonsense speech, trouble understanding speech, or difficulty reading or writing. If you get a really good baseline thinking skills on a patient and you notice any drastic changes, then this patient may be at risk for delirium. So all of these are good resources and good symptoms to use environmental and thinking skills to help diagnose delirium. Behavior changes and emotional disturbances. These are two other categories of symptoms that can happen in delirium. Some of the behavior changes may be seeing things that don't exist, so hallucinations, restlessness, agitation, or becoming combative. When someone is confused, especially in the elderly population, if someone's trying to help them up out of bed, help them to the restroom, they may become agitated and combative because they're not familiar with who you are, even if it is a family member. Calling out, moaning, and making other noises. A lot of this is due to fright. Sometimes this can happen at nighttime when a patient doesn't have a family member there and they may be calling out for them or calling for the nurse just because they don't realize where they are. some patients experience being quiet and withdrawn, especially, the older patients who experience delirium. They may just be to themselves and just not have kind of like a flat affect. Slow movement or lethargic, disturbed sleep habits, reversal of night sleep-wake cycle. Delirium is most common during the nighttime hours, so if they're not getting enough sleep that they should be getting, they may become delirious, and that can cause issues as well. The other category is emotional disturbance. So these are things that the nurse can assess when she is in the room with the patient, doing her safety checks, giving medication, or just visiting. Anxiety, fear, paranoid, depression, irritable or angry, a sense of feeling elated, rapid and unpredictable mood shifts, and personality changes. All these are really key for the nurse to assess throughout their stay at the hospital or new environment that they're in. And this will help the doctor to diagnose delirium in the hospital setting. I am going to talk to you about the pharmacological and non-pharmacological interventions to treat and reduce delirium. I would like to add in that although there are pharmacological options for treatment of delirium that do help, there is not a drug out there today that is only for the treatment or prevention of delirium. However, through evidence-based research, non-pharmacological interventions have proven to be effective when reducing the risk of delirium. First, I am going to talk about the pharmacological interventions used to treat or reduce delirium. A very common medication when doing this is antipsychotics. With antipsychotics, the initial doses may need to be higher than the maintenance doses. One of the common and most effective antipsychotics used to treat delirium is Haldol. This medication is normally the medication of choice, but can result in adverse neurological effects. Some other antipsychotics are Risperdal, Zyprexa, and Seroquel. Those three are actually a newer neuroleptic, and they relieve symptoms while minimizing the adverse effects. Another medication that is used to treat delirium is benzos or benzodiazepines. They tend to act more rapidly, and they have been associated with increased confusion. A common benzo used to treat delirium is Ativan or lorazepam. This medication is easy to give because you can give it both IM and IV, which is very helpful in certain situations. I also learned while researching that if an older adult has a vitamin deficiency, it can cause delirium as well. So I learned that giving thiamine and B12 can be helpful to older adults, especially if they have that deficiency, because that can cause delirium within them. staff adequately educated on what delirium is, what it looks like, what to do about it, how to act is very important. Also, keeping the patient reoriented throughout the day to the room, showing them where their call bell is, where the telephone is, where the bathroom is, maybe pointing out the light switch. Those things can be very helpful to these patients. I know at our hospital we have big whiteboards in every patient room, and the whiteboards kind of guide the patient throughout the day. They have information like the nurse's name and telephone number, the doctor's name. Some people write like when their next medication is due. Each board has an area for the plan of care. And we also put like our dining number so the patients can order their food on the board, just so that everything's right there in front of them and kind of helps get them through the day. In case they forget information, they can just kind of look up in front of them and see. And that has seemed to be pretty helpful. Having a multidisciplinary care team, including the RN, the CNA, physical therapy, occupational therapy, doctors, social worker, and case management, having everybody kind of on the same page and collaborating about patient care is very helpful for these patients that are at risk for delirium. Reviewing drugs with the patient, kind of going over what they're taking, why are they taking it, and kind of keeping them in the loop and just having them know what medications we are giving them and why they are taking it can be very helpful to these elderly patients. Keeping continuity of care is another big one. If a nurse is taking care of a patient for 2 or 3 days, they're familiar with the patient, they're able to recognize mental status change and can act quickly upon it. Over like a brand new nurse that has never taken care of the patient, this is their first day taking care of this patient, they won't notice those things so quickly. Keeping family at the bedside is important too. We understand that some patients' families aren't able to be with them. They may live out of state. But for the patients whose families do live nearby and come to see them regularly, having that conversation about keeping somebody with the patient, kind of helping them get through the day, having a familiar face is very, very helpful for these patients. And lastly, doing hourly rounding is big. Not only checking on the patient's pain, possessions, potty, but also doing a CAM assessment and assessing their confusion status. Are they able to hold attention? Do they have disorganized thinking? How their level of consciousness? Are they alert and oriented? Are they lethargic? Assessing that throughout the day is also very helpful when treating and reducing delirium.
So part of the treatment plan for patients who are experiencing delirium or ways to reduce experiencing delirium in the critical care setting is holistic management and prevention. And this would be non-pharmaceutical ways that include the mind, the body, and the spirit of the person to reduce delirium. So based on evidence-based practice, social impact is very important when treating these patients. So educating families on signs and symptoms is very important. Families tend to know the baseline cognition of the patients. Therefore, they can easily determine the differences between how the patient is acting at home and how they are acting in the critical care setting. So ways of doing this would be asking the families to tell us when the patient is saying inappropriate things, or if they're tending to their activities of daily living in a different manner than they would at home. We also want to speak to families about any daily devices that the patient may use being available at the bedside. This would be hearing aids, dentures, glasses, any accessibility tools that they may use. This is important in making sure that it is not something like impairment of hearing that is causing the patient to act in a different manner than they would if they were at home. Daily interaction and reorientation, not only from friends and family, but from nursing staff, and occupational therapy and physical therapy is very important. Activities such as reading, music, and puzzles, things other than the television that would create and engage different brain synapses and help the patient stay oriented. There is also early mobilization. It has been proven that early mobilization in stable patients can lead to reduced length of stay and reduced outcomes of delirium. So knowing this information, using passage range of motion on intubated or sedated patients to make sure that their muscles are, retaining that muscle strength, and beginning early mobilization in the bed and dangling on hemodynamically stable patients that are still intubated but are cognizant, and promoting early ambulation and use of chairs. The last subject that I wanted to touch on was sleep and sleep environment. The impact and prevalence of interference in sleep cycles has negative implications, including delusions, inattention, hallucinations, memory impairment, incoordination, and weakness, which are all common symptoms of delirium. So, knowing this information, it is important to promote the sleep-wake cycles of a patient. So, promoting regular sleep cycles through non-pharmacological interventions can not only prevent the patient becoming delirious from pharmaceuticals, but it also allows them to have the interrupted sleep that can create the time for the brain to basically re-energize itself. So we want to make sure that we're asking the patients, asking their families, what do they do to normally sleep at night? Do they have a special blanket they use? Do they use essential oils such as lavender? Do they have a white noise machine? Do they use rain effect or other effects of noise that we can easily produce on the television for them to sleep at night? What does the lighting look like? We want to make sure that we're dimming lighting in the room, but also making it an ambiance where the patient can sleep. One of the biggest factors that we experience in the nursing world is the fact that we have to still nurse at night, but how can we do this in an effective way in which we are reducing the amount of noise and interruptions, allowing the patients to sleep and still doing our work? This is and will always remain a challenge, but some things that have been known to help the unit is having a quiet zone, or reducing the lighting on the actual unit, or using a stoplight to help the nurses know that they're speaking loudly. These are all ways in which we can help patients non-pharmacologically and holistically get the rest and the interaction and the mobilization that they need to reduce or prevent delirium.
Implications of delirium. Many older adults end up discharged from their hospital stays still suffering from delirium that appeared during their stay at some point.
This delirium that they end up discharged with, it has lasting effects on their daily lives. Their cognitive functioning is affected, their emotional well-being, their mental health, and their physical health even is affected by their hospital stay and the development of the delirium. It ends up robbing these individuals of returning from their normal lives. They end up stuck in this haze that they just can't get out of. Even young, healthy adults that end up in the ICU that are discharged with delirium have this issue of it following them home and just not allowing them to return to their normal lives. The recovery from delirium can range anywhere from no recovery whatsoever to full recovery in a few cases. The older adult population tends to fall into that partial recovery spectrum where they're not fully able to get back to their normal lives, but they do have some ability to regain. So some of the inpatient implications that delirium causes for older adults is just an increased length of stay. These people are going to end up being in the hospital longer because of this delirium coming about. Unfortunately, the older adult population is also going to experience an increased risk of death while they're in the hospital because of delirium. Whenever a patient is mechanically intubated and ventilated and they develop delirium, it becomes an issue in terms of extubation. And unfortunately, these patients, especially older adults that develop the delirium, end up being on that ventilator longer than they technically needed to be because they're just not able to fully wake them up and bring them to know that they can follow commands and get that tube out in time. So they end up being on it for more days at a time than people that don't get delirium. There's also an increased use of restraints with delirium, whether it be because older adults that develop the delirium are trying to crawl out of bed or pulling IVs and different devices off of them. Maybe they're trying to self-extubate, so you see an increased use of the wrist restraints, the mitts, chemical restraints like benzos, Ativan, things like that. You also see the development of what's called post-intensive care syndrome, or PICS. It's a lot like PTSD in a sense. This delirium development, it becomes this whole syndrome within the ICU and the delirium that they all work together and just really, really disable these older adults in terms of getting out of the hospital and returning to a normal life. Some of the implications after discharge with delirium development, again, you're still going to see that increased risk of death with these older adults because of the delirium. Their global cognition is going to be affected. They are not going to be able to function on the level that they may have before they were inpatient in the hospital. Their executive functioning, again, that fog that we talked about, they just aren't able to return to that normal baseline that they were at. They may not be able to function in a motor capacity like they used to. A lot of times because of the delirium development with the older adults, these patients are at an increased risk of ending up in a nursing home as opposed to whether they were living independently or with family before, because there is such a decline in their status and such a caregiver burden if family was taking care of them prior to this all happening, that they're more likely to end up in a nursing home. There's an increased risk that they may be readmitted because of some adverse event having to do with this delirium following them home, whether it be they were confused and got up in the middle of the night, they fell, now they have a subdural and they're back in the hospital. All of these different things come together to just really not help these people in terms of staying out of the hospital and staying healthy. And there's also an increased risk of developing dementia if you are discharged after suffering delirium and it follows you home. Over 15% of patients discharged with the delirium actually end up developing dementia in the years that followed after their inpatient stay.
A famous quote by Floyd Skloot: "Dementia resembles delirium in the same way an ultramarathon resembles a dash across the street. Same basic components, but vastly different in scale. If you've run delirium's course once or twice in your life, try to imagine a never-ending version. This famous quote clearly depicts being in someone else's shoes with delirium. Prevention is key when caring for patients at risk for delirium. Put ourselves in their shoes. Think how it must feel to be confused, combative, or not even know how to perform simple activities. These patients could be our family members or even us in 30 plus years. Be an advocate for your patient and perform the necessary interventions to extinguish this prevalence. In conclusion, delirium is a syndrome composed of 4 subtypes, which are hypoactive, hyperactive, mixed, and no-type delirium. Delirium affects the older population more than any other population due to neuropsychological changes in the brain. Delirium is different than dementia because delirium is temporary, usually only lasting 6 months, but dementia is a progressive disease that is lifelong. Delirium can occur hours to days after admission and can last way through discharge and may require institutionalization. It is characterized by confusion, hallucinations, or even being combative. Many medications such as antipsychotics, benzodiazepines, and vitamins have been used for the reduction of delirium in the hospitalized elderly patient. Non-pharmacological methods such as diversional activities, mobilizations, and providing patients with their assistive devices, such as hearing aids and glasses, have been proven in helping reduce delirium in this population as well. Many patients admitted to the hospital have a longer hospitalization due to a diagnosis of delirium. Delirium also puts the elderly patient at risk for developing dementia, which might increase nursing home placement or possible adverse events or readmissions for secondary effects of this syndrome. Furthermore, be an advocate for your patient, provide all the necessary interventions such as medications and non-pharmacological interventions that could possibly reduce the likelihood of them contracting delirium in the hospitalized setting.
And first and foremost, I want to thank all the creators and developers of the articles and or pictures that we use in our presentation. Just say thank you.